First of all, I want to thank the organizers. It's always nice to see you all. You all are my friend Nafiza Ashwak, Turkey, who just presented. I think we still share a patient with an AL translocation. So today I'm going to talk about the role of immunotherapy for stage 4 non-small cell lung cancer with high and low PDL1. And trying to move the slide now, which is not moving. Okay, good. So what I want to discuss is in this slide is a busy slide, but I'm going to take you step by step, and we're going to review the evidence that supports the use of immunotherapy for non-small cell lung cancer. I'm going to start with the easy one, which is patients who have PDL1 of more than 50%. And this classification of PDL1 based on percentage was introduced by Merck. This is the way as Merck run the studies. And with time, we learned that different levels of PDL1 actually correlated with different levels of response, as well as duration of response. We also learned what percentage of the population has very low PDL1, has kind of intermediate, medium, and high PDL1 expression. And this has also been validated by several clinical trials. The original trial was the Keynote 010, and then validated by the CheckMate 057 and CheckMate 012. And what you see at the bottom is that as you get higher levels of PDL1 expression, you increase your chances of response, and also you increase the chances of having a more durable response to immunotherapy. The first study that took advantage of just having patients with PDL1 levels of more than 50% was the Keynote 024. So the Keynote 024 required patients to have at least 50% PDL1 expression to be able to enter the study. And the study randomized patients to pembrolizumab or doublet chemotherapy. This study was for all histologies, so it did allow for pemetrexed-based regimens as well as taxane or gemcitabine-based regimens. As you know, the study was a very positive study showing a benefit for the group of patients that received immunotherapy compared to chemotherapy. And that benefit of the immunotherapy persisted over time. There are follow-up from this study at 4 and 5 years that still show durable response. Now, there is a more kind of granular analysis of levels of PDL1 and response. And there was one study that looked at PDL1 levels of 90 to 100% compared to PDL1 levels of 50 to 89%. And as you can see in the Kaplan-Meier's, those patients that have high PDL1 expression, 90 to 100%, almost double the responses that you have when your PDL1 is 50 to 89%. Again, this is one where having a high PDL1 level usually works as a nice biomarker. Now, how about patients who have low PDL1? So I'm going to be talking for the next couple of minutes about the group of patients where you have any level of PDL1 expression that is more than 1%. Can you treat those patients with just immunotherapy? And the answer is yes. Any histology with a PDL1 of 1 to 100% can be treated with just immunotherapy. And the studies validating that statement are the Keynote 042, the Empower 110 for single agent immunotherapy, and the CheckMate 227 for doublet immunotherapy, that is EP plus Nivo. The Keynote 042 was a very large study, a study of almost 1,200 patients that randomized and one-to-one patients with any PDL1 expression to immunotherapy or a chemotherapy combo. And the chemotherapy was indicated based on histology. The study did stratify patients based on PDL1 expression and was looking at the primary overall survival for patients with more than 50%, more than 20%, and more than 1% PDL1 expression. And believe it or not, the study demonstrated that across all PDL1 expression levels, that is more than 1%, 1% to 49%, and more than 50%, the patients were having superiority when they were exposed to to immunotherapy compared to chemotherapy alone. And again, you can see how as you increase the levels of PDL1, you get a better response. But even with low PDL1 levels, you're still having superiority over chemotherapy. The ipilimumab plus nivolumab study, which was a complex study presented at multiple meetings, multiple forums, was a study that was divided in two parts, 1A and 1B. And the only difference between 1A and 1B is that the 1B included immunotherapy plus chemotherapy. This arm that had nivolumab plus chemotherapy was the only difference between the 1A and 1B study. And the study is interesting because if you look at some of the results from the 1B part of the study, at 3 and 4 years, patients who have squamous cell carcinoma histology actually had very good response. And this is for patients with very low PDL1 also. So for us, for patients who have low PDL1 expression and have squamous cell carcinoma, this regimen is a regimen that we tend to use if the patient does not have a contraindication for the use of doublet immunotherapy. Now, how about the group of patients that have less than 1% PDL1 or that have PDL1 of 1 to 49%? This is the point where chemotherapy has been incorporated along with chemotherapy plus immunotherapy. And data from studies done in vitro as well as animal studies, it showed that if you test just immunotherapy alone, you have less tumor growth inhibition that if you use chemotherapy, for example, shown here in green, or if you use a combination of chemotherapy plus immunotherapy, shown here in red. In other words, when you add chemotherapy to immunotherapy, you have more tumor growth inhibition. And this has been proven also when you combine chemotherapy agents such as cisplatin and pemetrexed. It's also known nowadays that chemotherapy actually promotes anti-tumor immune response. As chemotherapy works on the tumors, those antigens that are released to the circulation increase the effect of the immunotherapy. You also activate some innate immunity. And the other thing that immunotherapy actually helps chemotherapy is that immunotherapy actually reduces the negative immune effects of chemotherapy. So the two complement each other quite a lot. And that has been the rationale for combining chemotherapy with immunotherapy, at least for the treatment of non-small cell lung cancer. Now, for patients who have a PDL1 of less than 1%, how can we treat those patients? Well, if you want to use chemotherapy plus immunotherapy, the best regimen is probably the one that was tested in the CheckMate 9LA study, where they look at nivo plus EP in combination with 2 cycles of chemotherapy. So this was a study where nivo plus EP was given with chemotherapy, and this was compared to chemotherapy alone, a 1-to-1 randomization, and the study again was positive, and positive in favor of the immunotherapy plus the chemotherapy arm. And what is interesting from that study is when you look at the group of patients who have a PDL1 of less than 1%, you actually have a good chunk of patients having a positive response to the treatment. This is 17.7%. It's not as good as the one that you see for patients with high PDL1 levels, but you see that this number was actually superior than the numbers for those patients who have more than 1% and very close to the numbers for the patients that more than 50%. So yeah, at our institution, if the patient has no PDL1 and we feel that the patient benefits from chemotherapy plus immunotherapy, this is our regimen of choice. 2 cycles of chemotherapy plus immunotherapy followed by maintenance immunotherapy with EP plus nivo. Now, when you look at patients who have less than 50% PDL1 expression, there are regimens that actually have studied the treatment with chemotherapy based on histology. And in the case of adenocarcinoma, Keynote 189, IMpowers 150, 132, and 130 look at that combination. For the Keynote 189, the study looked at pembrolizumab plus chemotherapy because this is adenocarcinoma, then the chemotherapy regimen is a pemetrexed-based regimen, and that was compared to a pemetrexed-based regimen, 4 cycles of chemotherapy, and then the patient is followed by pemetrexed plus pembrolizumab for up to 31 cycles. For the group of patients who received chemotherapy, the maintenance was given with pemetrexed, and at the time of progression, they were allowed to switch to the pembrolizumab only regimen. As some of the other studies, this was a positive study indicating that at 2 years, there was a difference of about almost 16 points, 45.5% versus 29.9% in the group that received chemotherapy only. Again, in blue, you have chemotherapy plus immunotherapy. In kind of orange red, you have the group of patients who received chemotherapy only. And the slide shows all the other studies that look at adenocarcinoma histology with a combination of chemotherapy plus immunotherapy. For the keynote studies, it's going to be pembrolizumab. For the Empower studies, it's going to be tislelizumab. And you see that there is the Kaplan-Meiers show a benefit favoring chemotherapy, even when you add a biologic such as Avastin, and that was the case of the Empower 150. Now, for squamous cell carcinoma histology, if you have less than 50% PDL1 expression, 2 studies, Keynote 407 and the Empower 131s, were the ones that validated that chemotherapy plus immunotherapy was superior to chemotherapy only. For the Keynote 407, pembrolizumab was combined with chemotherapy in the form of carboplatin plus either paclitaxel or nab-paclitaxel that was given for 4 cycles, and then the patient started maintenance pembrolizumab only. And then for the control arm, it was placebo plus carbo, paclitaxel or nab-paclitaxel, and then that's what followed by placebo. The time of progression, patients were also allowed to switch to the immunotherapy arm. And you see that across all PDL1 expression levels, there was a benefit for the group of patients that received immunotherapy plus chemotherapy compared to chemotherapy alone. Again, quite substantial for the group of patients who have more than 1%, even more than for the group of patients that have more than 50%. And again, the slide shows a comparison of the 2 main trials, the Keynote 407 that is using pembrolizumab, the Empower 131 that is using atezolizumab plus chemotherapy. The 2 studies again showing superiority when you add immunotherapy to chemotherapy compared to chemotherapy alone. And the slide, which is a busy one, is just a compilation of the studies looking at immunotherapy plus chemotherapy for non-squamous histology. These are the 4 trials that I mentioned before. And immunotherapy plus chemotherapy for squamous cell carcinoma histology. And these are the 2 trials that we just discussed. Now, not all of these studies actually achieve an endpoint of improving overall survival. Empower 132 did not reach that endpoint, as well as Empower 131 for squamous cell carcinomas. So for those reasons, this combination was not FDA approved in squamous cell for the indication of squamous cell carcinoma. Now, for any PDL1 immunotherapy, and I want to emphasize that any PDL1, including high PDL1, immunotherapy plus chemotherapy is likely better than immunotherapy alone. And this evidence comes from a study that was presented at ASCO this year, where they look at the outcomes of patients treated with any immunotherapy, any anti-PD1 or PDL1 in combination with chemotherapy. And you see that when you look at the overall survival is better for the patient that receive immunotherapy plus chemotherapy as opposed to, for example, chemotherapy alone. And that also translates into an improvement in the progression-free survival. And when you look at the hazard ratios, this is positive across all the variables, with the exception of the never smokers. As you know, those never smokers usually have a driver mutation, and those are the patients that do not get a benefit from immunotherapy-based regimens. So when we have a patient where we suspect that the patient has a driver mutation, for example, and we still don't have the results of the molecular testing, we usually do not give immunotherapy. We just start the patient on chemotherapy if we feel that the patient is very symptomatic or has bulky disease and needs to start immediately on treatments. So what we know so far is that you can boost the effect of the immunotherapy by adding chemotherapy, even when the PDL1 is negative. And this evidence comes from pool analysis from the Keynote 021, the Keynote 189, and the Keynote 047, where again, if you have chemotherapy plus immunotherapy shown here on green, and you compare that to chemotherapy, there is a benefit of having the combination of the two agents. And if you look at patients who have PDL1s of 1 to 49%, these two studies actually prove the same thing that was demonstrated in the pool analysis presented at ASCO this year, and that is that chemotherapy plus immunotherapy, shown here in green or shown here in blue, is superior to chemotherapy alone for this group of patients. Now, if we look at which one of the chemotherapy agents, when you are treating patients with squamous cell carcinoma, seems to have a superior outcome, is it paclitaxel or nab-paclitaxel? The evidence, at least if you look at the hazard ratio, seems to go in favor of nab-paclitaxel, at least indicating that potentially nab-paclitaxel, when combined with immunotherapy and carboplatin, is superior to paclitaxel, carboplatin plus immunotherapy. I don't pay too much attention to this data, by the way, and I find nab-paclitaxel to be more intense. Patients have to come more often for treatments as opposed to carboplatin and paclitaxel, which is a dose every 3 weeks given along with pembrolizumab, for example. Now, finally, I want you to be aware that some interventions may compromise the response to immunotherapy, either in a positive or a negative way. This was also presented at ASCO this year. This is a study that Mark Sosinski presented based on a pool analysis of the IMpowers 130, 132, and 150. And he was trying to look at the potential association between immune-related adverse events and the efficacy of first-line atezolizumab. So he looked at these 3 studies, and he pooled the patients who have immune-related adverse events in the atezolizumab arm and also in the control arm. And I want to clarify this. The patient that received chemotherapy also had some immune-related adverse events. If you look at those trials, there are some immune-related adverse events. So what he is presenting here is a comparison of the immune-related adverse events, grade 1s and grade 2s, by the way. These were not grades 3s or 4, in the group of patients that receive atezolizumab as part of the treatment versus the group of patients that just receive chemotherapy. And interestingly enough, if the group of patients who have grade 1s and grade 2s, I'm not talking about grade 3s or 4, immune-related adverse events actually have better overall survivals, even in the control arm. So this is interesting. Even in the control arms where patients are not receiving immunotherapy, if you have some sort of immune-related adverse event, that's telling us that the immune system somehow is being activated for that patient, and those patients do better. But what is interesting is for the group of patients that are receiving immunotherapy, they have grade 1s and grade 2 immune-related adverse events. We know that they're going to do better, and this is evidence that that is true. Now, there was also another study presented at ASCO this year that looked at patients that were exposed to antibiotics. And the rationale is that if you take antibiotics, you are changing the microbiome of your gut, and that somehow affects your response to immunotherapy. So they look at patients who have received antibiotics prior to starting immunotherapy. That's within 30 days before the initiation of immunotherapy. And they also look at another group of patients who receive antibiotics within 60 days following the initiation of this immunotherapy. And what they notice is what we see here in gray is the patients who do not receive the antibiotics doing better than the patients in blue that receive the antibiotics. And this is for the prior exposure of antibiotics. This is antibiotics before immunotherapy, and this is antibiotics after immunotherapy. Again, showing that patients who receive antibiotics don't do as well as the patients who do not receive antibiotics. Again, showing one more time the effect that has the antibiotics and changing the microbiome and the potential response to immunotherapy. And finally, and these are my last two slides, we have studied the potential effect of mutations in being more sensitive or more resistant to immunotherapy. This was a study by Drisby, where they look at the MYSTIC study, one of the Durva studies, and they found that mutations in genes such as KEAP1 and STK11 are associated with poor responses to immunotherapy. And whenever you see this combination of mutations or even one of them, you can predict that the patient is not going to have the best response to immunotherapy. We have also noticed that patients who have MDM amplification, for example, they are more susceptible to have hyper responses to immunotherapy. Now, steroids do not affect the response to immunotherapy, and this is the last of my slides. And I want to thank you. This is my email in case that you guys have questions later on.
Well, thank you, Prof. Molina, for this nice review. I guess we're going to leave the question till the last presentation. So